Great. Welcome back, everyone. So now we are moving to a Blueprint for Health proposal as part of the governor's proposed 2024 budget. And I think to start, what we'll do is just a quick introduction around the table and around the room so everyone knows who's here, and then we'll turn it over to all of you. So Art, would you like to start?
Yep. Representative Art Peterson, representing Clarendon, Wallingford, West Rutland, and the part of Rutland Town.
Leslie Goldman, Wyndhamsbury, Rockingham, Westminster, and Brookline, which is the Bells Falls area.
Representative Rebecca, representing Winooski.
Representative Cordes, Lincoln, Bristol, Moncton, and Starksboro.
Topher McFarland, I represent Barrytown and a part of Williamstown.
And Lori Houghton, I represent the city of Essex Junction.
Alyssa Black, and I represent a portion of the town of Essex.
Colin DeMar, representing Enosburg and Montgomery.
We may have a couple more coming in and out. Mike, do you want to start introduction?
Mike Fisher, healthcare advocate. Dave Goodler, Department of Health.
Matthew DeGroat with Action Circles.
Mary Kay Woolman, West State Primary Care Association.
Wade Mullen, Legislative Attorney.
Rebecca Cobans, Blue Cross.
Christina McLaughlin, with the Bird Demonstration.
George Karavakakis, CEO of HCRS.
Great, wonderful, thank you. Appreciate your coming. Can you say what it stands for?
Healthcare and Rehabilitation Services. We're one of the designated community mental health systems serving Lincoln County.
Great. Wonderful. Welcome. And if we'll turn it over to you, John, and then you can introduce your team as well. We'll get started.
Okay. Why don't I just put the first slide up and we'll introduce ourselves as I can. Okay. Yes?
Yeah. Yes.
Great, thank you. Well, good afternoon, Madam Chair, Lori. Thank you. I'm John Saroyan, Executive Director for Blueprint for Health with my colleague in the Department of Health.
I'm Elisa Stolberg. I'm the Director of Maternal and Child Health in the Health Department.
And Commissioner Levine, would you just introduce yourself briefly before we start?
Hello, everyone. Sorry I can't join you there. Mark Levine, Commissioner of Health.
Great, welcome.
Well, thank you so much for inviting me back and for inviting us to present supporting access to mental health and substance use disorder services through integration with primary care. One note off my script, the proposal is available under reports in the legislative sites. It's about 2.5 pages. This is a more detailed presentation. Also, the Blueprint annual report is available under reports on the legislative site. And I encourage you all to not just look at the report as a whole, but to look at the area of the state you're from. There's multiple stories in quotes from our community health teams describing the work that they do in very concrete, digestible, bite-sized kind of detail. So I look forward to you all reading those as well. I'm here today in response to Section 7 of Act 167, which requires recommendations on, quote, the amounts by which health insurers and Vermont Medicaid increase the per person per month payments toward Blueprint for Health's community health teams and provide quality facilitation in furtherance of the goal of providing additional resources necessary for delivery of comprehensive primary care services to Vermonters and to sustain access to primary care services in Vermont. It is important to recognize that today's proposal also has been informed by multiple pieces of legislation that direct state agencies towards the development of an integrated and holistic system of care, specifically including the Blueprint for Health. As I described in my testimony on January 20th, the Blueprint for Health is an established and ambitious program to integrate high-quality primary and community-based care. The mission of this program is to support providers in delivering a long-term, whole person approach to care, one that addresses medical, social, and mental health needs and provides access to a range of supportive services in an integrated fashion. The Blueprint supports patient-centered medical homes, community health teams to promote care coordination, panel management, and integrated care. Patient-centered medical homes supported by community health teams are also intended to support people who need additional resources to address health-related social needs such as housing instability, economic fragility, food insecurity, transportation challenges, and need for long-term placement. While the Blueprint has a clear and demonstrated results through independent evaluations, investments in the Blueprint have not kept pace with the demographic shifts in Vermont's population or with increasing mental health and substance use disorder treatment needs. Now is a critical time to reinvest in and enhance this tested healthcare transformation infrastructure of the Blueprint and to use these tools to strengthen integrated primary and community-based care so that our vision for whole person healthcare is accessible to all Vermonters. We have prepared today's proposal following an in-depth review of the most recently available scientific literature. Again and again, studies show the value of integrating and strengthening mental health and substance use disorder treatment within the primary care setting. This approach has been proven to be more effective and affordable than fragmented care and results in greater satisfaction for patients and providers alike. I have one of the handouts that I'm not going to go into, but that I'll show to you all is the evidence to support increased access to mental health and substance use disorder through integration with primary care. And I summarized for you all, not just the state of Vermont's evidence around this, but also New Hampshire, Rhode Island, New York, state of Washington, Pennsylvania, Michigan, Ohio, national data, and then international data. So it's a very comprehensive and I think reader-friendly document. I've also had the opportunity to meet with our teams at each of the Blueprint Health Service area administrative entities, which consist of 11 hospitals and 2 federally qualified health centers. Through conversations with leadership and frontline workers, I have been able to compile a detailed summary of current challenges, needs, and priorities for our communities. These findings have been supported by further discussion with professional organizations and community-based providers. I've also provided you all with the handout, not necessary to go into it now, but with a summary of those findings. This is a one-pager, so not quite as long as the first. Throughout development of this proposal, we have had frequent collaboration and communication across the Agency of Human Services. In the wake of the COVID pandemic, community need for mental health and substance use support has never been higher. Vermonters of all ages have been affected, and primary care providers are tasked with addressing the ripple effects of these challenges in our communities. While our community health teams continue to do great work under challenging circumstances, there are too few community health workers, social workers, and counselors across all health service areas. This is not only due to workforce shortages, but also because community health team funding has remained unchanged since 2015. With many competing demands on their time, healthcare professionals struggle to address substance use disorders not related to opioids, as well as related to opioids, but other substances too, like alcohol, methamphetamine, and the use of multiple substances in conjunction with additional mental health and medical concern pose added complexity in the primary care setting. Families of young children are particularly struggling. For instance, depression and anxiety is climbing, with 1 in 4 pregnant or postpartum Vermonters now experiencing difficulties. And when it's available, families can benefit from wraparound care and encouragement to engage with supports and services. Quality improvement facilitation support for primary care practice is essential for optimizing pathways to specialty referrals and transitions of care, ensuring ongoing delivery of high-value care and improving patient experience. The evidence-based support for integrated primary care is really the starting point of this slide, and the Blueprint is deeply integrated with these efforts in Vermont. While the percentage of people across the state has varied, close to 75% of all Vermonters are currently seen in a Blueprint recognized practice. All patients served by Blueprint practices, regardless of insurance status, have access to regional or practice embedded community health team staff who provide enhanced care coordination, wellness services, and supplemental healthcare supports that have been prioritized by their local healthcare providers. Blueprint-funded program managers, practice facilitators, and community health team staff, in conjunction with Blueprint primary care practices from the primary implementation workforce, work to reform and create these efforts in all of primary care. Despite these existing networks, and social safety nets. Rates of death by suicide, opioid-related fatal overdoses continue to rise. Feedback from providers continues to emphasize the need for greater capacity to address mental health and substance use conditions where patients receive primary care. For these reasons, we have chosen to prioritize provision of integrated substance use and mental health care in this proposed expansion. This aligns closely with work of the Mental Health Integration Council, which began convening in July of 2021 as a result of legislation passed the previous year. The council, just for background's sake, is charged with helping to ensure that all sectors of healthcare actively participate in the state's principles of mental health integration. This proposal is also consistent with recommendations from the National Academies of Sciences, Engineering, and Medicine to increase investment in mental health and substance use disorder services and integrate these within primary care. Ultimately, this proposal leverages the Blueprint's existing foundation for practice transformation and multi-payer investment to promote mental health and substance use services through a 2-year Medicaid pilot, which will allow for evaluation and potential recommendation of future commercial insurer investment. The need for community health team expansion. The National Alliance for Mental Illness estimates that 1 in 5 Americans experience mental illness and 1 in 20 Americans experience serious mental illness each year. Federal surveys indicate that at least 5 to 15% of adolescents and adults, depending on their age, experience a substance use disorder in a year. Vermont has the highest suicide rate in New England and the 18th highest rate in the nation as of 2020. At the end of 2022, Blueprint for Health community health teams composition statewide was about 10% counselors and social workers and less than 5% community health workers, all of whom are team members who have expertise to respond to mental health needs. This pilot proposal seeks to increase that staffing by requiring that increased investment be spent on community health workers, social workers, and counselors, as well as create consistent funding for the Dulce program, which Elisa will speak to in just a couple slides. That is for the very young infants of 0 to 6 months and their families. We propose an increase of Medicaid payments to community health teams of $4.68 per member per month. This would increase existing community health team payments from $277 to $745, as seen on this slide. This amount was determined by considering current rates of mental health and substance use disorders, anticipated community needs for the duration of the pilot, the need for Dulce family specialists. We are not recommending an increased rate for the commercial payers at this time, and I will now introduce you to the specific elements of this per member per month amount so you can see some of the considerations, many considerations that came into place to lead to this amount. Calculating the per member per month increase involved assessment of current community health team staffing, estimation of the population need, the type of staff, as well as the ratio of provider to patients and duration of care. For Dulce, the calculation was similar, except that practices were assessed for willingness to implement the program. The expected improvements. Community health workers are frontline public health workers who have an in-depth understanding of the community they serve, usually with shared ethnicity, language skills, or life experiences. They often function as liaisons to bridge the gaps between the community and social services, facilitate access to high-quality, culturally competent healthcare, and decrease healthcare disparities. They may also perform a variety of specific activities, including community education, care coordination, coaching, outreach, advocacy, and social support. All tasks that can increase the provider's ability to ensure that their patients' social needs are met. Community health worker interventions have not only been linked to improved chronic disease management, improved mental health outcomes, and decreased hospitalization, but also to have proven return on investment. And that multi-page document that I included in your handouts has multiple examples of $1 invested, how much is saved. Repeatedly positive return on investment. The addition of more community health workers to our health teams is one evidence-based way to further support Vermonters with complex medical and mental health needs struggling to navigate the healthcare system. During 2022, Blueprint program managers estimated that it takes approximately 3 months to recruit and hire a community health worker. Unlicensed mental health clinicians, counselors, and social workers may require a minimum of 6 to 12 months to recruit and hire. Licensed clinicians and counselors, that much and even longer. Community health workers appear to be more readily available, and that's hence the emphasis in this proposal. In addition, increased funding could be used to expand the hours of existing staff members and allow them to partner more frequently with designated agencies without requiring as many new people hired.
Can we stop? Because I think there's probably some questions that have come up. I know I have a couple. Daisy?
Can you confirm that community health workers are in this case rate?
Sure.
Or in-
By case rate, you mean the PMPM?
Yes, they are.
They are.
And are they at DAs as well?
There are only 4 or 5 community health workers in all of our community health teams right now, and 1 or 2, I believe, is through a designated agency, though I'd have to talk to my team to confirm that. There are very few community health workers on our community health teams right now.
On the Blueprint
yeah.
community health teams, but you say there is a broad availability of community health workers outside of the Blueprint.
What I've been told is that with the training offered through the Department of Health, which is actually at no cost right now, and some of the grant programs that AHEC is running, what I've been told by our program managers that they could recruit, train a person to be a community health worker often in 3 months.
Do you know if community health workers are in the case rate at DAs? I don't believe they are.
When you say case rate, I'm just not familiar with that term.
Are they reimbursable under Medicaid?
My understanding is that there's a consultant working on that right now, and I'm not remembering their name. My team has been in touch with them. Community health team services would be available when there's not reimbursement. It's not broadly available, and I can follow up more in detail, but I know that's a person who
or maybe
the Department of Health is actually contracting right now to explore community health worker billable. That's the word I use.
My question is community health workers, are they reimbursable under Medicaid right now in Vermont?
That would be a question for Diva.
Thanks, David.
Mike pointed out, of course, I should identify my voice as David Engler.
The three areas where community health workers are supported by grants right now are Washington County in a doula program, North Star Health, which is in Springfield, to support their mobile medical unit, and then also there's a new community health worker program in Rutland. Each of those is grant supported, so they're not presumably they're not billing Medicaid, and that is that absence of a sort of formidable regular reimbursement stream is another reason for emphasizing them within this proposal, since that's what community health team members fill, is that gap when a service is not billable.
It's an important service.
Go ahead, Leslie.
If you want to go.
No, go ahead.
I'm just curious if you could give me an example of a day of a community health worker
Sure.
in this context.
So one of the community health workers I met, no, actually I didn't meet, I heard about when I was visiting St. Albans, is dedicated to an entire community that I believe it's hard for me to recall everything that I knew, but she actually spent time in that community where diabetes was highly prevalent and attended appointments with people and visited them. Visiting in home varies from place to place. I'm also thinking of community health worker who there's a couple in St. Johnsbury, and in that community, my recollection is that they do have a fair amount of flexibility of where to meet people, including the emergency department, the person's home sometimes, and in clinic. So their day is quite flexible depending on the needs. I believe it was in Rutland where one of the, no, that's a different type of professional. In other communities, community health workers follow-up from referrals from the emergency department when an individual has a new diagnosis, doesn't have insurance, or some issue or problem that needs follow-up that very next day, and takes the first sort of step at the reach out and really tracking down where that person is. So there's a variety of different things that they that they do. I also I know that I'm going into more detail maybe than you want, but Sally Kraft at Dartmouth, I'm meeting with. I included one of her publications because she's done a whole pilot within the New Hampshire kind of side of the Dartmouth system about community health work. Sometimes they're actually based in offices.
That's what I was wondering. So I was.
So it's pretty variable.
I mean, you're mentioning.
It's pretty variable.
So, yeah.
Which I appreciate that flexibility, especially for people who don't trust healthcare providers. I mean, there's all sorts of issues that come up that I can certainly remember as a provider, and an individual would share with someone who wasn't the doctor, but would share with someone who they saw more as a social support.
Thanks.
Melissa?
So you're just requesting, you're not asking for commercial payers or Medicare to increase their amounts.
We're not asking Medicare or commercials to increase their amounts now. What our plan is that this would be a pilot with evaluation to make a recommendation based on our results of evaluation.
So if the blueprint serves everyone, you're basically asking for state dollars to care for everyone. And you're not asking the commercial payers and Medicare right now, which
at this time we're not asking Medicare or commercials to participate. That's correct.
Can you explain a little bit of that rationale?
Sure. I think that the dollars, the funding is available through Medicaid, and I think that testing the program in that setting is an opportunity to take with a goal that's within 2 years to make recommendations, perhaps to expand beyond it.
Go ahead.
Could you, and I know, and I'm going to save my questions other than this till the end, because I know you're going to go through what the pilot will be. But do you feel you could do more with the pilot if we did have commercial or Medicare in? Could you serve a broader group of people? Could you provide more programming? Could you get to an answer in a year instead of 2 years?
More dollars equals the potential for more FTEs. There are some that question even hiring this many FTEs in this amount of time. That's a possibility. It's a possibility depending on the community. If the positions were hireable, more dollars would equal more hireable people. Could we get to the answer more quickly? I am going to talk about the evaluation, and sometimes I get a little technical with my answers. So I don't know as if more people would get to the answer more quickly with the lag time on data, but I don't mean to avoid your question. I just.
And one last question on this. Could we ask Medicare to increase? Is that even possible? That's not possible, correct?
I haven't, I'd have to review that in terms of that's negotiated through a different mechanism. These mechanisms that I'm looking at right now based on Act 167 are very much all based within the state and within our abilities. And I don't want to get too far outside of my scope. So
that's fine.
I can't answer that one very well.
Okay. Maureen? Oh, I'm sorry. I cut Alyssa off, so let her finish.
Just for my own knowledge, okay, so we received Blueprint, it's Blue Cross Blue Shield pays in Medicaid, traditional Medicare. Do Medicare Advantage, on Medicare Advantage?
No.
Okay, so, and we're.
Does everyone know that what that question is? Just Medicare Advantage?
Yeah, so the proportion of Medicare Advantage insured lives in Vermont is increasing.
Correct.
Okay, so we're losing money from Medicare for those patients, we're losing the per member per month on those because they're moving to Medicare Advantage plans. So we're actually decreasing the amount that Medicare is kicking into Blueprint.
I don't know the numbers, but
Okay.
one would wonder, yes, what's the shift and what, I don't know what those percentages are. The Medicare Advantage plans don't fall under the rules of the type of insurance required to contribute to the Blueprint. Their contributions would have to be through some, I guess, statutory. I don't know how those changes would be made. That sounds over my head.
So,
And I'm just thinking that the rationale for the increase in self-insured plans is the same, which is basically we have less paying in, but still the whole is being served.
right, we serve the whole population with less payment. And I am gonna ask if someone from the outside wants to comment on the Medicare piece, and you do not have to if you don't want to.
I'd be happy to.
Okay, if you can introduce yourself and then.
Mary Kate Molman, Bi-State Primary Care Association, formerly worked for Blueprint. The Medicare dollars for the Blueprint currently come through the all-payer ACO model. So it's not even a PMPM at this point, it's a lump sum. And that is the only way that the Medicare dollars continue to come in to support the Blueprint program. Medicare Advantage is not, and the self-insured are also not. Only for the commercial side, as far as I understand, it's the Key piece and the fully insured. And those are the plans over which the state has regulatory authority to
Right,
induce
yes.
participation.
Thank you, Mary Kate. Yeah.
Maureen? Thank you, Mary Kate.
I feel like we're beating a dead horse at this point. Back to the question about why not Medicare, why not commercial insurers in this project? And is it, I want to try to rephrase it to understand it. It's related to capacity, scalability. I mean, that it's a scale that this group can manage right now. And you want to, it's the size of a project that you can use to test, whereas it might not be as effective if you had a larger group.
I think what you're expressing for the first part around scalability of doing this stepwise, given workforce shortages, is an accurate and a congruent assessment. That's the first part. For the second part, could we get there faster? I mean, I think that there's it's tough. It's tough. One would imagine more people would get more services, and one would want to do that. The measurement of effect, I'm not sure would come any faster, except people's experiences matter. So that part, and that's why I'm including in our evaluation a qualitative or interview based, like with patients and providers aspect, so that it's not just numbers. Numbers are very important, but I am proposing in this that some of that analysis or evaluation includes stories as well.
But if you were looking at this as for example, a research project, you're limiting the variables to make the analysis a little more manageable at this point. And partly because
if I were doing this as a research project, I would be I would be careful not to get too far ahead of myself with how big I got, how fast.
Yep.
And that doesn't mean I'm in any way minimizing people's needs right now or the impact that one person can have on another person in one moment even.
Yep. Thank you.
Thank you.
So I have actually one last question, and then I promise we will move on. So this is around the funding piece of it and how it's working out. And I see in the budget proposal that there is obviously state fund dollars that seems to be drawing down global fund
Correct.
dollars.
The federal match, right?
Would it be possible to decrease the state dollars, add in commercial, and still draw down the same Medicaid amount of money? So could we free up Medicaid money by being holistic and saying we want commercial and Medicaid to move together in Blueprint and still draw down the global commitment dollars that are needed.
I don't have as sophisticated an understanding of global commitment dollars as others, but it's been described to me as a match. So the state invests X amount, there's a formula to then
Right.
show what the match is. I don't know if there's like a minimum investment or anything. One would think that if the difference in dollars was slightly less or whatever amount less, the
Right.
ratio would stay the same. But I don't know those.
That would be something we'll want to get answered. So can the match be Medicaid and commercial together? Or is the match only Medicaid?
Match is based on Medicaid investment from the
Is
state.
only?
Yeah.
Okay. All right, thank you.
Was that the crux of it?
Yes.
Okay, that I can
Where I'm
answer.
coming from, so like if we put in $1 and we get $2, so what if we put in 50 cents of Medicaid state dollars, 50 cents of commercial? Do we still get the $1?
It's based on only the
Only the
state's
Medicaid.
contribution
Okay.
to the general fund is.
Okay, thank you. All right, let's.
No. That's my understanding.
Okay, let's maybe get more clarity on that. That would be great.
Yeah.
Okay.
Some of this definitely gets to the edges of my expertise, so thank you for your
Yep,
understanding.
no, that's fine.
So
All right, let's keep going.
screening, prioritizing efforts for screening, prevention, and earlier treatment of mental health and substance use disorders can improve identification and support for nearly 75% of Vermonters served in Blueprint practices. Screening and assistance navigating to further services when indicated is equally, if not more important for our youngest Vermonters, infants between the ages of 0 and 6 months. I'm now going to pass the mic to my colleague, Elisa, who already introduced herself. And Elisa, I'm happy to move the slides along for you as you talk to the group.
And Elisa, we know nothing about I want to say nothing. I know very little about the Dulce project. So just keep that in mind as we,
Yes.
there's others in the room who don't as well. So.
Great. Well, thank you for having me. Thank you to Dr. Soroyan for inviting me along. I'm really excited to talk about Dulce with you today because it's a real highlight of our work, even throughout the pandemic. And so we're just really proud of this program and really excited about the opportunity for expansion. So just a little context for Dulce. We've been, Dulce came to Vermont in 2017. It's a evidence-based practice out of the Center for the Study of Social Policy. And we were one of the original 4 sites in the country to implement Dulce, and we've grown it to the degree that we can. We've mostly funded it with initially private foundation funds and now some dollars from CDC and from One Care Vermont, but we've really just been coupling it together. All of that money is expected to end. And so embedding Dulce into the Blueprint for Health really provides a sustainable path for existing programs and the potential for expansion over the next couple of years. So we're super excited about it. Dulce, as I mentioned, is an evidence-based approach that proactively addresses social determinants of health, promotes the healthy development of infants from birth to 6 months of age, and provides support to their families in the pediatric health setting. Dulce, as you can see here, is a comprehensive, interdisciplinary team. Dulce stands for the Developmental Understanding and Legal Collaboration for Everyone. And it's really the 3-sector approach that combines the medical healthcare experience, the early childhood system of care, which is in our state is largely representative of Children's Integrated Services and how those teams operate at the local level, and then the legal partner, which in Vermont is Vermont Legal Aid. And I'll talk a little bit about why the legal partner is so important in just a second. So the way that Dulce works is that Dulce employs a family specialist who's actually an employee of the local parent-child center who comes and works full-time in the pediatric office. And that relationship is really key because that person is bringing all of the expertise and the situational awareness that they understand about the early childhood system in those local communities into pediatric health care. It's just a beautiful partnership that we feel really excited about. The family specialist meets with every single family with an infant birth to 6 months in that practice, and comes to every well child visit and builds that relationship over time. And they provide, as he said, this essential bridge back to the system of services and supports for families. They, which could be home visiting, early intervention, childcare supports, financial supports, substance use. And then the legal partner is also part of this team and is part of a weekly case review and is listening for places where there are legal barriers that may get in the way of the family being able to parent and operate to the best of their ability. So where there are housing challenges, immigration challenges, sometimes there's healthcare, financial pieces. And so because they're listening and they're trained to hear in this way, they're able to forecast any legal challenges that may and proactively address them and work with those families who may need them. So not every family needs legal supports and services, but it's an opportunity to get that happening early on. And so, as I mentioned, Dulce is a universal practice. So every family is offered Dulce, and it has the absolute best engagement I've ever seen in a program ever in my life. That 99% of families say yes to Dulce, and they don't really have to do anything different. They just have another person who comes into that visit, and builds that relationship. And so nearly every family who is in that practice who has Dulce is benefiting from this service.
Where are these these services located in these towns?
They are, I might get them.
It doesn't, you're not mentioned all over.
Yeah.
Normally, are you into a clinic?
Yes, they're all in pediatric health offices. Yeah. So what happens in Dulce is that if every family is screened for a series of health-related social needs, so social determinants of health. So they're screened for food security, housing security, their needs for childcare, intimate partner violence, parental caregiver depression, that whole gamut of the substance use. Vermont has over the years innovated and added substance use screening into our service delivery, which is new or not new to Vermont, but which is not done all in other parts of the country. So it's something we feel really strong about. And then families who screen positive or screen for needed supports are then linked back to the early childhood system, or linked back to treatment, or linked back to housing services. And there's just really incredibly high rates of connection because you have this trusted relationship of this family support worker, who in some cases is actually a community health worker or a peer, someone who's, we had one site in Newport where the family support worker was actually a graduated Dulce family. And so they kind of had gone through this experience. So they're screened and then they're connected back to services and care. And one of the important things to remember about Dulce, because it's a universal program, is that we're picking up on needs or concerns very early. We're picking up on them because this is a brand new family. There's a newborn or a really young baby in that family. And at the same time, we're asking these questions of everyone. So we're destigmatizing to some degree, and we're we're not just asking people who we think may be experiencing this. We're asking and we're finding out information that we wouldn't have normally found out, and therefore the early intervention and supports can happen at a much sooner period. Dulce finally is just it's a strengths-based parent resiliency. It comes at it from what the family brings to the situation and really works with the family's strengths and needs and connects. And you can see we have 6 sites right now in Vermont and I'm going to have John lead you forward. So we, with this funding proposal, we will upscale Dulce from 6 sites to 12 sites. And there will be a full-time family specialist in each of those sites supporting the infant practice.
So are the sites, the parent-family center, I'm not saying the right name.
The Parent-Child Center.
Parent-Child Center, is that where they are? Or are they in a pediatric?
They're in a pediatric primary care office. They are an employee of the Parent-Child Center.
Thank you, okay. Mari and then Lizanne.
Looking ahead at the map, I don't see Addison County there, and there's a Parent-Child Center in Middlebury. Is there a Dulce?
There isn't at the moment, but we have had we've had conversations with all of the parent-child centers, and the original set really came from where the parent-child center and the pediatric practice were both ready. I think now that we've been doing this for a number of years, we'll be able to sort of push that along. I think our dream is that there's Dulce sites across the state, that every child or every family would have access to this. I think we have some thinking to do about how we would roll this out, but I do imagine that we'll be able to touch most parts of the state with expansion.
Thank you. Leslie?
I'm wondering what happens after 6 months.
That's a good question. So in the Children's Integrated Services and the Parent-Child Center still are engaged with families, long past when they turn 6 months. So families who continue to need services and supports will still be connected to those services and supports.
By the same person, or will that person go away and they have to find another person? Like, how does that?
Well, they would be handed off to the CIS team. So they would probably begin working with a different family specialist, or if they're working with home visiting, they would continue to work with them.
And in the proposal and in our working together, there would be more crossing with the community health team resources.
Absolutely. And in sites that don't, because it's a full-time human, it works with there's a kind of a sweet spot of the number of infants in that practice. We do have 2 sites, the Mount Ascutney sites, that don't meet sort of that capacity of infants. And so what we've done is expanded that, and they work with families up until age 6 or age 8, and sometimes they work with new families, sometimes they are families who didn't ever have the opportunity to participate in Dulce, or sometimes they work with Dulce graduates or past the 6 months who still are benefiting from those services and support. So it's a little bit of a tailoring based on what the needs of the Parent-Child Center and the pediatric practice are.
Okay.
So really, this is just this slide talks about kind of where we would like to go with this pilot funding. That there would be 12 clinical sites. They would serve as a resource to the sort of entire health service area around, for consultation. And that we'll have to do some more planning around, and really they provide that ongoing assistance to families to navigate the services and supports in that community. On the right side of the slide, you can see really just some of the measures that we're looking at around the percent of families who are engaged in the program, who both start and then graduate, how many or what percentage are screened, what percentage are connected to services and supports like financial supports, childcare, and other resources and services. So I really just want to end, and I'm happy to answer any questions by just reiterating our enthusiasm in this program. We've seen exceptional outcomes already. We think we could do incredible things for children and families through it. We have a beautiful partnership with the pediatric practices and the parent-child centers. I think if you wanted to talk with them, I think they would share that as well. And we're just really excited about where we could bring and the opportunity that the Blueprint could bring to expanding Dulce to meet really more children and families.
Alyssa? So I'm looking at all the services that they're gonna provide, which I think is wonderful, but I keep coming back to, and I'm not on human services, so I don't have a big grasp of that.
And I will, let me start with, we don't know what parent centers are
Yeah.
here. So
Yeah.
that's-
Yeah.
Where they are, so I have my own. community and-
So I'm gonna let her finish.
Yeah.
I think your
I
context.
I'm thinking about like reach up, caseworkers in DCF. Isn't this essentially what they do? And why don't we just embed people in pediatric offices where the families are?
Yep. Well, I mean, that is what the beauty of this program is. That is where families are. There's an extraordinarily high percentage of infants and families are seen in those first 6 months. So it's like no other way of accessing. So and the parent-child center. So there's a parent-child center in every community. In Burlington or in Chittenden County, there are 3, I think. And the parent-child centers are also members of the Children's Integrated Services System, which is a state-run system and operated in each community that serves that Agency of Human Services region. And their job is to work in coordinated fashion to ensure that children and families receive needed services and access to supports and are referred out to wherever they need to be in the system. So they would work and make sure that families are connected to reach up if there was a need for financial supports. That parent-child center staff often help actually complete whatever application is needed. And so it's, for me, the best way to think about it is it's that hub, right? So, or the bridge, really. The pediatric office is the access point to connect with families and get in early. And they, parent-child centers, Children's Integrated Services teams know better than anyone else in the state what's happening in that community and how to, they know the names of all of the agencies and how to navigate those systems so they can bridge out to where those services are, where families need that are tailored specifically to families.
Thank you.
And so is it only the one pediatric office that the Dulce helps, or if there's 4 pediatric offices in a community, can they work with families in all 4?
Well, so that's a good question, and it's something that we're grappling with. Right now, it's a singular, there's one human that supports just that pediatric practice. It doesn't necessarily work for them to be in more than one practice because they can't physically be more than one place, and there could be an infant in that practice down the road and an infant being seen at the same time. So ideally we would have a one full-time human in the majority of practices. Now, we have a lot of small practices in Vermont, pediatric practice, and then we have a family medicine practices that also see infants and young children. And so I think there's some innovation and adaptation that we can do. We've been starting to wonder about telehealth. Could they sit in one place but participate via telehealth? We think that the expertise of that person could support a larger group of practices, but they wouldn't necessarily be able to visit every family. So there's some work we have to do to work that out, especially in those smaller practices. That's the only handful.
Thank you. So I know Daisy has a question, but could you provide any data on the success of the program to us in writing, since this is the first time we're really.
Absolutely. So this one pager, which I think John has some data, and we'd be happy to provide you with more data, both in Vermont, and then there's been there's national data that's been published around emergency room utilization, around adherence to the Bright Futures, which is really the guidance about sort of how pediatric healthcare should happen.
Great, thank you. Daisy?
Thank you so much for coming in. And I have heard much about this program, and everything I've heard sounds wonderful. But this is a lot of change. Your funding is ending. You're transitioning your funding mechanism. At the same time, you are proposing to more than double your staff at a time that we are in a national workforce shortage. I'm curious if you can speak to your rationale for this timing that you're choosing to do this pilot. What gives you the confidence that you're going to find this staff, and knowing that you're going to be pulling staff with unique skill sets from other providers, if you do feel confident that you're going to find them?
Yeah, that's a great question. I did forget to mention the high degree of engagement that we've had, and the staff, both at the Parent-Child Center and the pediatric health staff that participate in Dulce, we've seen pretty significant reductions in burnout and real high engagement among the staff. It's a win-win. That integration has really been extremely positive. So I think it's a really attractive role to take. We've certainly had conversations with the Parent-Child Centers, and they could share this with you at all. They feel confident that they could recruit staff to do this. It doesn't necessarily require a certain kind of degree or a certain kind of experience. And so it really does allow us to lean into a community health worker model or a peer model, so that there's kind of expanded definition of who could do this work. It's not necessarily a population or a workforce that is in as high demand as the mental health clinical workforce or nursing workforce. And it really helps to free up the capacity of all those other professions that work with families, so that people are working kind of according to their scope of practice and really at the highest point of their training. Sure.
Leslie, did you have a question? And then we do need to move on so that we can finish the presentation.
I'm just curious to know what the starting salary is for this role.
We're crunching the numbers now. We're right now, the Parent-Child Center sort of set their own schedule, but we are using average salary around $55,000.
$55,000 a year.
Mm-hmm. Plus benefits and all that comes.
And that's for someone without a degree necessarily.
Not correct. And that would be really up to the Parent-Child Center to determine based on their salary structures.
Great, thanks.
Okay, thank you so much. I'm going to turn to the quality improvement facilitation of this portion, and I will be mindful of time to move along. Quality improvement facilitation, as a reminder, is a systematic approach that emphasizes continuous efforts to reduce variation and improve quality of healthcare delivery. Current Blueprint funding supports 11 quality improvement facilitators. While facilitators have been instrumental in increasing screening rates for mental health and substance use concerns, they're not adequately resourced to focus on improving referral pathways and creating best practice community or learning collaboratives related to mental health and substance use. In our proposal, by expanding the QI facilitation program by 4 staff, we plan to have those learning collaboratives establish specific define quality targets for participating practices and better ensure effective monitoring of outcomes, improving access and coordination of mental health and substance use disorder services. Facilitators are also equipped to support systematic expansion of programs and quality improvement. So they would be helping this program to be successful, making sure the measures and the focus is on those targets. In order to support increased treatment of mental health and substance use disorder, the proposals including the 4 FTE QI facilitators for a total of 400,000 and the staff and provider training of 300. I'm sorry, my screen is blocking part of my screen. And that is in addition as a reminder of the amount for the community health teams. Commissioner Levine, I have the first slide up. I welcome you to conversation.
Mark Levine again, Commissioner of Health. I guess because I'm in the cleanup position here, batting position, and I get to make a few comments based on what I've heard, and then go on to what I want to tell you about the expansion in our hub system of care. But my first comment is that the scope of what we're talking about today is going to be much larger than the 10,000 individuals who are currently going to hubs in Vermont that I'm going to discuss. And I wanted to reemphasize, I believe Dr. Saroyan's terms, that we are in a crisis time, and it is time for innovation and creativity, specifically regarding the status of the mental health, substance use, and other issues that we have seen be exacerbated by the pandemic and that are now quite accelerated. I am a co-chair of the council he presented earlier to you, the Mental Health Integration Council. And I would like nothing more than for our council to come out with a wonderful set of high and lofty recommendations at the end of this year and then see them implemented. But realistically speaking, we need to act now. So much of what we've done in our council can inform this discussion, but it should not delay our ability to be innovative and creative. There was some talk about the payment structures for Blueprint with commercials, et cetera. And my only comment there is just to state historical fact. And historical fact is that Blueprint traditionally has done everything that it has done, and that is very successfully, as you've heard, with Medicaid being the payer. And with our relationships with the federal government, CMMI, and global commitment monies, to being able to be innovative in that space. The hope has always been that commercial insurers would follow, but even subsequent changes after the original system went into play with the hub and spoke system, Women's Health Initiative, all began in the Medicaid space. And then I can't resist but to say something about Dulce because it is such a priority for myself and for the health department. And I can only say that just like just like nurse practitioner-led home visiting programs to this same susceptible age population, the 0 to 6 months of age, with mothers who are quite new to that task quite often, and in a population where in Vermont, unfortunately, our statistics are not very braggable when it comes to the rates of different substances being used by pregnant mothers, by those who are postpartum, and the rate of relapse, and all of the issues in those mothers' lives. The healthcare system, and I say this writ large nationally, really is embracing the role of addressing the so-called social determinants of health. And that's at the level of screening, that's at the level of providing brief interventions or more long-standing interventions. And what we're presenting to you today is completely consistent with that. And embedding the individual who's the family specialist in the pediatric practice automatically destigmatizes the entire process, makes it a part and parcel part of the healthcare system's role, and the pediatrician's real dedication to improving the lives and health of not only the new infant, but the entire family. So those are my brief comments. And I would not be restrained by the fact that it is a very competitive workforce environment and we have challenges galore. But the entire healthcare workforce is quite beleaguered, as I'm sure you've heard a lot of during this session already. And we need to be as competitive as possible in attracting people to that workforce by paying a living wage and providing the kind of gratifying and affirming work that many of these positions can provide. Now you'll see on my first slide here just the distribution of hubs. For those who aren't familiar with the hub and spoke system, spokes are really the practices that you've heard about from Dr. Saroyan all along. They're primary care practices. Sometimes they're OBGYN or mental health practices, or actually a specialty addiction specialist person, but mostly they're primary care. And in the substance use treatment arena, they are responsible for maintaining people on buprenorphine. The hubs, on the other hand, are where addiction specialists are located. They are the only places to obtain methadone, because methadone has to be at what's called an OTP, an opioid treatment program, prescribed by such specialized individuals. So that is why we have them. That is a complement to the spokes. But there are many individuals that require methadone or require more intensive services, even if they're on buprenorphine, and making the hub the right location for their care. The reality is that hubs are already providing some of the kind of co-occurring care that I'm going to refer to, but the reality is also that they do have staffing and workforce shortages. They have space issues in their own facilities. And definitely need the expansive approach that we're going to be outlining here. If you could move to the next slide, please. Lest you I'm sure you did realize this, but you may not have realized the degree to which people with opioid use disorder have complicated lives. And this is data from a study we did several years ago that was an evaluation of the hub and spoke system. So when you see almost half of the people with a mental health condition, that's on a sample size of about 100 individuals. But nationwide, the number is often thought to be in the 70 to 80% range. But then just again, to show how complicated the lives are, we tell you about the number involved with the legal and law enforcement system, coexisting hepatitis C, usually from injection drug use, homelessness, substance use throughout the household, and then the number of children people have, some of which are living with them, some of which actually are not. So very complicated lives, and one would imagine needing a lot more services than just a daily dose of methadone to stabilize everything. If you can move to the next slide. Knowing that there are mental health issues, there are substance use issues beyond opioids, and there's general physical health, getting immunizations on schedule, making sure your risk factors like blood pressure and cholesterol are monitored. If you have coexisting hepatitis C, being able to get that treated. All of these are really critical interventions for the individuals here. The goal is, if you will, to enable one-stop shopping, a real holistic approach to healthcare, which of course is what this whole presentation is about. But when we think about the hubs, we think, I think, in a very compartmentalized way about managing the opioid use disorder in someone with a complicated life. I know I want to emphasize many people are successful who go to hubs. They're holding down a job, they're maintaining their family, etc. However, think about how complicated it might be to travel to a hub, get your dose of medication, have to travel back somewhere, and then also keep a couple other appointments if you're so inclined with a mental health counselor, with a general physician who can provide you with hepatitis C treatment, etc., and get to your job on time and hold that job. So the picture I'm trying to paint is not exaggeration by any means. It really does make it seem like if we could deliver more at one location, it would be very, very useful and helpful. Something we all expect when we go to our doctor, unless we need to be referred for some super specialized element of care. And on this last slide, just to talk a little bit about where we came up with what we came up with, the real core issues, which unfortunately were left off the slide, are really engagement and retention of people who are in treatment for opioid use disorder. As I mentioned, there are almost 10,000 people going to hubs today. We think that there could be an additional 1,170 individuals who are not seen at the hub location, but have intensive enough needs in the locations they're at that could benefit from this expansion as well. But rather than focus on the additional 1,100, I'd rather you focus on the close to 10,000 who really will benefit from having this expansive array of services available. The actual investment, first of all, there will need to be capital improvements in each of the hub facilities. Some of that will be simple, like they need a special set of refrigerators or whatever for vaccine management. Others will be, well, they need a place to draw people's blood to see if they actually require treatment for hepatitis C, or they require another room to do some mental health counseling in, aside from the rooms that are being used to deliver the opioid use disorder management. Some of the money will, of course, go to workforce. You can't escape that anywhere. Trying to make that an attractive pathway for workforce and recruit effectively. And there's going to be a fair amount of need for education and training because not everyone is going to be familiar with how to manage hepatitis C with a sophisticated set of new drugs. Not everyone is going to be as aware of how to manage someone with stimulant disorder, if most of the people have been managed with opioid use disorder. So there will be need for that educational training on top of that. So again, the hubs are trying to do this to some degree, but I would say we can enhance their opportunity for success tremendously by pursuing this expansion that we're mentioning here, which again is built on a $2.3 million per year times 2-year pilot premise. I will stop there and you can either ask questions now, or I think Dr. Saroyan has a few more slides before the presentation is done.
I think we'll take like 2 questions and then because I do want to finish. My question is, if this pilot is implemented, do you think that it would free up space at primary care providers to see other patients who are not connected to a hub? Does that make sense? So people who, as you said, were going to the hub for one thing, but then might be going to the primary care for something else. Does that free up space at a primary care practice?
The answer is probably yes, but the impact would be probably very low.
Okay.
Number one, because if people have a good relationship in their primary care practice, they're not going to want to leave it. But number two, again, we're talking, 10,000 Vermonters. So if you distribute that across the entire state, it may not have a huge impact on any one practice.
Thank you, Alyssa.
So you said that approximately 10,000 people are being served currently in the hubs and another 1,170 in other areas, other offices that you're not sure of. How many Vermonters?
They're like VAs, Spectrum, places like that.
Yeah. How many Vermonters do you think are out there that we're not serving at all?
Yeah, that's always an important question. And nationwide, it's about 1 in 10 who have opioid use disorder are actually being served. In Vermont, not that we're arrogant, but based on survey data that we performed, we think we're closer to 4 and 5 in 10 that we're serving. That still leaves a lot of people, but that's actually fantastic considering. The number one reason people with opioid use disorder will tell you that they aren't in treatment is because they do not perceive they should require treatment.
You don't feel as though there are barriers? I mean, you know, you talked about the challenges of the hub system and just what it's like for a person daily to get to work and all of that. I mean, has there been thought of, rather than investing in wraparound services, investing in, you know, making things more accessible for more people to get treatment?
Funny you should mention that, because we just had on Monday a meeting of the Opioid Settlement Advisory Council. And there are a number of proposals that came out of that meeting that have the intent to do exactly what you just described. It's really the health department's motto: meet people where they are, meet Vermonters where they are. So it's some of these efforts involve hublets, which are sort of the progeny of larger hubs that could be located in geographic areas that would provide more access. Some of these are doing more outreach. There's a host of proposals that really try to take people who might not engage in the traditional treatment structures that we have, but still be agreeable to treatment because we've kind of met them where they say they can be. So our recommendations have not officially come to the legislature yet, but we envision that happening over the next several weeks. But stay tuned for that. We are very much thinking that way. And the only thing that's really limited us over the many years of the hub and spoke is that most of what we get for funding is the federal government's funding, which, for better or worse, often has very tight strictures around it, and one can only use for certain dedicated sets of activities. And it's never, even though we love the amount of money we get, and it's millions and millions of dollars, this is a huge problem. And we can't pursue every innovation that we'd like to over time with those dollars. So though the hub and spoke system has been, you know, arguably the most successful in this country for addressing this problem, you're correct that it is not sufficient.
Thank you.
Thank you.
Thanks, Commissioner Levine. In terms of measuring the impact of this proposal, we plan to utilize a mixture of quantitative and qualitative measures as seen on this slide. We will specifically be on the left hand be utilizing mental health and substance use related health effectiveness and data and information measures. Those are called HEDIS measures for short, which are standardized, validated quality measures established by the National Committee for Quality Assurance and widely reported by Medicare, Medicaid, and commercial insurers. Additional sources of qualitative program feedback may include surveys of providers, program participants, process measures, and staff member interviews. And the total cost of this is estimated to be, for the evaluation and analytics portion of our proposal, is $350,000. The timeline for provider engagement, I want to just comment that the Blueprint has always valued provider and stakeholder engagement through its development, and I'm proposing in this process, one overall work group, as well as at least 3 subcommittees to embark upon more detailed planning of the screening tools, the referral workflows, the outcome measures, the data collection, review of evolution of payment methods, and then the structure, because we're going to embark upon this even as we await the legislature's evaluation and decisions is in front of you. So meeting monthly as a large group, and then meeting twice a month for smaller clinical evaluation and payment committees. And this is very much the way other parts of the Blueprint expansion over the years have been done in a similar manner. Is that a short amount of time to do all of this work? Yes, it is, but we will do it. And then overall, and I believe this is my last slide, so that you all can just see the summary of what I hope we've presented in adequate detail is in front of you. I did not go out further decimal points, and certainly if that's something desired, I could do that, Chair Houghton, but I did, just for my own sake, I didn't go out to like the
That's fine.
1,000th, 10,000th decimal points.
Great. So I do have a question on the funding, and then I know Leslie and Brian have a question. So.
May I take our slides down?
Oh, please, that would be great. Yes. No, actually, can you just leave this
Okay,
one
I'll leave-
up?
yep.
Yeah, actually leave this
Sure,
one.
just want to be
So-
sure.
So this slide encompasses everything, which is the quality facilitators, the Dulce program, the expanded community health team, the expanded hubs teams, the analytics, for $4.6 million in general fund. Yet the amount that we received in our budget general fund is $8.8 million. So would love to just, when you, at some point, if you can, let me know what the variance is there. So, and so we have, and then there's a whole lot of money in global commitment and federal funds. So I can send you what I'm looking at, if that would be helpful.
I'll forward it to our financial.
Yep, and I would love a detail.
Clarify it, absolutely. of
Thank
course.
you. Yes, I will copy you, and then, yeah, Daisy's our budget.
Sure, of course, yeah.
Leslie?
You know, I think this program is really interesting. I'm someone who cares a whole lot about social determinants of health and early intervention and everything that could go along. As I said, I'm worried about what happens in 6 months, but I'm going to have to trust you guys with that piece. But I'm wondering about the evaluation. If you're in so many different settings, how are you going to manage the confounders and the variance between all your different parent-child centers and everything that is going to go into evaluating these programs?
Blueprint has partnered with a group for many years, I think almost from the beginning, that I was just talking to them the other day, that has a tremendous amount of expertise in states of our size, but also the states of Washington and California. And I would be with this group in very frequent contact with them to do that. And both the timeline for planning and the timeline for looking for results, I think in research terms for changes and investments of this size they're accelerated. Like we need to know things quite quickly. They don't seem daunted and seem up to the challenge for it. I'll have to rely on my statistical partners though for that level of sophistication. And if that's who ends up getting used, the group I have in mind, I have a lot of confidence in them.
Hey, Brian?
Yeah, I wanted to ask a little bit more about as you're talking about the strengthening of the integration of mental health and substance use into the primary care system. Our committee's been taking testimony about suicide prevention, and we've been talking about, I believe, I don't remember which witness said that the last healthcare provider most people who died from suicide saw was their primary care physician. And so I'm just curious if you might have anything, even though you're not here necessarily for that topic, it does interconnect with what you're doing. I'm curious if you have any ideas or suggestions about how we might reduce death from suicide and even further, like address the triggers and drivers of suicide through primary care?
I guess I'll say two things, and then maybe Commissioner Levine and Elisa might join in too, Representative, if that's okay. When we surveyed our practices last year, our screening rates were quite good and quite high on an annual basis at the annual checkup or visit, where I see improvement being possible without overburdening staff and individuals coming in, is to perhaps to look at screenings that happen maybe not at the annual visit. So a screening perhaps that might come in if the person's just seen. That's one, I think, thing that I've heard in terms of what you're saying. The other part of it is, and suicide is not my clinical expertise, but what I hear from members of my team and also our community health teams themselves and providers is, if it's possible for there to be a connection at the time a concern is coming up, that connection does so much generally to prevent a lag or a time frame passing where things can get worse, a referral maybe doesn't get closed or happen. So what I'm thinking and what I've been hoping this proposal would do is to decrease the amount of time someone would have to wait between bringing a concern up and having someone to talk to, in addition to their provider, but really to explore it more broadly and create a connection and a plan to provide them with some additional safety net. Those are not perfect answers, I realize, but that's conceptually how I'm approaching it. The second part of your question relates to, I think, the drivers of those of the factors, the triggers. I mean, for me, again, this is not the end all answer, but I think the emphasis in early childhood that Dulce specialists bring to me is really on the prevention end of addressing those things early. The emphasis on community health workers and those who I've met who figure out people's challenges, knowing what the medical system is, but also knowing what the social systems is around a community are extremely valuable and have been shown to hold value. Again, I will share humility and say, I know that's not everything. I know that doesn't take everything into account. But for me, it's a significant shift in emphasis that will be felt and I hope will be measurable.
Ask one follow. Just that's useful. I took down some ideas from what you said. That's what I was writing. And what would you say? And if I missed this in the presentation, sorry. But what would you say would be the greatest barriers to access to primary care at this point for people? Because it sounds like we have a lot to offer people once they get there. But what are the blocks, or what are the things keeping people from going to their primary care providers from your perspective?
We same group of people, our Quality Improvement Network, did a survey with our Blueprint practices in December, and I think other professional societies might be able to speak to this better. And I'm going to be hearing a presentation in greater depth about what those barriers were in about 2 or 3 weeks. What I've seen initially from that look at the end of last year is if a practice has a significant number of retirements or people leave the area, I'm thinking in my own mind that there's a very strong association between that and wait times for a primary care doc. So if one community has several physicians of a similar age who, not necessarily physicians, but providers who all retire or just kind of close up shop, I'm starting to wonder as I look at the data from across the state, oh, no wonder maybe that wait time is so great. The XYZ practice is closed in the last 12 months and they had to shift people off to many other practices. So that's one idea I have to answer that question more specifically. I'm not sure if that's what's in your mind or your constituents, et cetera, but that's what I'm watching as data comes into me.
Okay, it's helpful. And just what I heard is one of the greatest barriers to access is the number of openings available to people due to the workforce or something like that.
I think that's a basic, yeah.
Thank you.
I'm sure there are many others.
Can I pipe in for a second?
Oh, of course, Commissioner Levine, sorry.
First of all, I wanted to refute what Dr. Saroyan said about his competence in answering these questions, because he's done a great job. But I do want to emphasize on the suicide question, number one, the screening part, and that primary care is and will have to be forever a team-based sport. So the whole benefit of having a Blueprint, having community health team members, having a greater team surrounding a patient is to accomplish some of those things like screening. That's very, very critical. Second thing is in terms of more the general population approach to suicide, so much of the programming now that you're hearing about in Vermont and nationally, much of it based on so-called zero suicide, but there's plenty of others as well, really is a whole of society approach, meaning that yes, the healthcare sector has a role and needs to be attentive, but it's people who know people as well. Not being afraid to ask the question because that doesn't precipitate the act. Not being afraid to bring it to someone's attention because you're concerned about them and want to have them get help immediately. All of that. So the whole process of screening, using your own internal level of concern as a gauge, the whole process of what we call warm handoffs, whenever somebody has any concern, knowing exactly where to turn with that and make sure you guide the person to the next step. Not that these will eliminate all suicides, but they are certainly major steps in that direction. And the 988 number, of course, is instrumental in Vermont. But if it wasn't brought to your attention, the Facing Suicide Vermont site is so important as well, especially with the testimonials from those who have survived suicide attempts and gone on to live a very productive life, but also families of those who unfortunately were successful and what insights they can impart. Thanks.
Great, thank you, Commissioner. I have one last question, especially based on all this talk about primary care providers. So I understand and appreciate the importance of the community health teams, but in this proposal, there is no increase directly to the providers, and I'm wondering why that is.
Sure, we followed very much the statutory language of Section 7 and looked broadly, but also had to make choices. And focused on the statutory language that was guiding us specifically to community health team and quality facilitation.
Thank you. Okay, I appreciate your time and your proposal, and we have providers coming in on Friday to provide some testimony, and we'll probably be reaching out with more questions. And I'm going to send you an email on the numbers.
Yeah, sure, and I can forward that and get clarity.
Great, thank you. Thank you, everyone.